Hopefully everyone can hear me okay. My name's Erin Probert. I'm the clinical lead speech and language therapist here at the RHN in Putney. You're also going to hear from two of my colleagues, Zoe Gilbertson and Taryn Morrish, from the SLT team. So yeah, we're here to talk to you guys today about how we're using flavoured foam tastes with our patients here at the RHN. There's been lots of interest, bring people contacting us to ask kind of questions about how we're using it here. And, so lots of conversations happening on Twitter and things about sort of flavoured foam taste and using sort of the BioZoom system with sort of a range of different client groups. So what we kind of wanted to do today really is give an overview of kind of what BioZoom is and give a demo of kind of how you use it in case anybody isn't familiar. Give a little bit of information about how we're using it here at Putney. We've done a patient trial and got some data out of that, which we'd like to share with you. And also we want to just discuss some of the practical points and considerations and things that we've kind of learned through our use of BioZoom. So I'm just going to very quickly to start with, why is that not moving? There we go. Just say a little bit of something about the hospital here. So we're the Royal Hospital for Neuro-disability, RHN, and we're an independent medical charity. So we're not an NHS hospital, but the vast majority of our patients are NHS funded to be here, either for rehabilitation or kind of very specialist long-term care placement. So we've been around for a very long time, since 1854, and we're obviously based in London here. And we have a range of different services as part of the hospital. So we have a level 1 neuro rehabilitation service. We have a number of specialist nursing home wards. And then we have a range of sort of highly specialist services. So we have a couple of ventilator units for people who require long-term ventilation. We have a Huntington's disease unit. We have a neurobehavioural rehabilitation unit. And we also have a unit for young adults with learning disabilities as well. So we have a real broad kind of range of different areas of specialism here. Okay, so I'm going to hand across to Taryn now, who's going to start us off.
Thanks, Erin. So what is BioZoom? Something that we as a team were really excited to hear about. I think it was at the end of 2018, early 2019, and we did our best to read up on it and get our hands on it. And we started using it here at the hospital quite early on with our patients across the different services. And BioZoom is the name of a particular product, and they call themselves an air flavor system. And what it does is it allows people who are unable to eat and drink normally to have the experience of having tastes again. So the idea is that you choose your selected liquid, you mix powder into the liquid, and you then aerate it, and it creates a really light foam, which you spoon off the top and you can provide it to patients. So BioZoom is, obviously marketed to patients who are nil by mouth and primarily peg-fed, and it's very much marketed as taking away the need to swallow because it doesn't present a bolus. And this is definitely something that we were interested in to explore further. And we also had questions ourselves around that because, although it is only bubbles that do dissolve in your mouth, there's coating on the bubbles, and we were very curious to find out a bit more what the impact this would have on our patients, and to also explore the response of patients to the taste and see what if there were any changes in their salivary responses and whether it would encourage swallowing. So we thought we'd start off just doing a demonstration and showing you the parts of the BioZoom system in case perhaps people have only heard of it and not seen it before. So we're just going to adjust the camera a little bit and give you a demonstration of how to prepare BioZoom. Okay, so this is the little device. It's really small, and this is the pump. It is battery operated, and you attach a silicone tube to the top of the pump, which is quite long, which is really handy. Another part of it is a plastic pipette, which is perforated, so it has lots of tiny holes on the end, and you just attach this to the end of the silicone tube. Okay, so you then select a drink with your patient and put it in any container. You generally use about 50 mils of liquid. And the BioZoom comes with these sachets of powder, so it's called Air Instant Powder. And what you do is just empty that into the liquid. The powder is coloured, it's got a slightly orange tinge, but it doesn't have any flavour. So you still have the flavour of whatever the drink is you've prepared. So you just give it a little bit of a mix.
I think the main kind of point of the powder, from what I understand from the manufacturers, is that it's a couple of ingredients that stabilize the drinks, that when you make the foam, it's more stable and doesn't sort of disappear so quickly that you can't get the bubbles off.
Yeah. So you then submerge the end of the pipette into the liquid and you turn the pump on. And it works its magic and creates a whole layer of bubbles, which hopefully you can see nicely. And then the idea is to scoop the bubbles off, and that's what you'd be giving your patient. So you're not getting any of the liquid at the bottom. The bubbles, as Erin mentioned, do tend to last quite long, but if you are perhaps in a session and you find that the bubbles are disappearing, you can always just put the pipette back in and you refoam it up. So you're able to do that as many times as you need to in a session. The only thing is that the pipettes are single use. So after one session, we discard of them. And then we also have quite a stringent infection control to cleaning the device, which we'll cover again at the end of the talk. Okay. So that's just to give you a bit of an idea of what it looks like. And then thinking of how we use BioZoom. So there aren't many or aren't any published papers out there that exist currently that we've come across as to the use of foam tastes. But we've been using it here at the RHN for over 2 years now. And these are some of the applications and situations we use BioZoom in. So we use it very often with patients who are in a disorder of consciousness. So we do want to assess their response to gustatory stimulation, but perhaps reduce the risk of aspiration. So whereas traditionally you might use a bolus of a spoon of yogurt or a sip of drink, we tend to at times start with BioZoom to reduce the risk of having a bolus. We've also found it useful to use in our patients and residents who have chronic severe dysphagia and who are nil by mouth. And are perhaps nil by mouth for the long term. And this is the group and cohort of patients that we've chosen to do our trial on, which we'll go into towards the end of this talk. And it's the group of patients we use to really get some feedback on and see the impact on pleasure and quality of life that this could bring to them. Other applications are for patients who are end of life, and it's used perhaps for comfort, for enjoyment. So perhaps if a patient unfortunately is not safe on any fluid or food consistency, it could be that foam tastes be used to provide them with that enjoyment, or perhaps used to moisten their mouth because it does induce the salivary response. And then lastly, we've also found that we're using it as a tool for our dysphagia rehabilitation. So using it to try and stimulate swallows because it gives such an intense taste. And also using it for practicing swallowing maneuvers that perhaps we otherwise would have done with dry swallows. So just provides a bit of a stimulus and again, takes away the risk of using a bolus from the get-go. So when we looked at our application of BioZoom, and particularly now whilst we're writing up on this trial that we've done, we did quite a lot of reading, and the drive behind using something like foam tastes is for quality of life and really focusing on holistic patient care. And whilst we try to look up accounts of people who are nil by mouth and have been for a very long time, there's not much out there in terms of studies or research other than personal reflections. But there are quite a few accounts from people who have been nil by mouth for a long time. And there was one particularly powerful one that we came across, and it was a blog post written by an Australian woman who suffered a brain hemorrhage at the age of 21. And she spent the following 10 years being nil by mouth. And she described that experience as a living nightmare. And I think we all know how much more there is to oral intake than just sustenance. I mean, it gives us so much routine in our days. It provides social interaction opportunities. It's part of active care for people we love. And it's often a big part of our culture, our identity. It's part of celebrations and big occasions. So not having access to this, as we all know, is really isolating. And I think having the option to participate to some extent using something like foam tastes is a concept that I think is very exciting for people who are nil by mouth. And it's definitely something that we've tried to use as a quality of life approach here at the hospital. So we'll go into our trial that we did here at the hospital. And since we were using it quite routinely as part of our speech therapy service and our clinical practice, we thought that we would do a reflection to try and gather some data and find things that we could report back on, because there just isn't much out there at the moment. And I think a lot of people are hesitant to bring this into their services because there's very little evidence out there, that maybe highlights risks or encourages use. So we included all patients across the hospital with whom we trialed the foam tastes and who had sufficient detail on their responses. So we managed to collect information on 14 patients. And when we looked at the range of diagnosis across the participants, it was very varied. So we had patients with Huntington's disease, hypoxic brain injury, brainstem infarcts, MND, stroke, and neurodevelopmental delay. And what we did is we tried to look at the different levels of cognitive ability in these patients. And in order to try and make it a bit more measurable, we used the DST, so the Decision Support Tools rating of cognitive ability. And of the 14 participants, 13 were low needs, 3 were moderate, 3 were high, and 5 were severe. We also didn't exclude trachea patients. So 5 patients were tracheostomized, and some of them also were for 24 hours cuff up, which we'll touch on a bit later because it's something that we found quite interesting. 3 of our patients were trachea and vent, and 6 patients had no tracheostomy, so a nice range. 8 of the 14 participants were already on saliva management medications, and 6 of those had also had Botox to their saliva glands. So again, we didn't exclude participants who we knew that saliva management was problematic for. And the average length of time post-brain injury for the participants was 7 years and 3 months. And the average length of time that they'd been nil by mouth was 1 year and 7 months. So just to give you a bit of background on the patients that we included, and I'll hand over to Zoe now to talk a bit more in depth about the details of the trial.
Hi, so it was a retrospective study. So as Taryn pointed out, the inclusion criteria was that the forms had been completed in enough detail that we could include them. We went for 3 trials for each patient. Now, some did have more trials than that, but that felt like a reasonable number to get a sense of whether this was the right technique for them. All the trials were either a speech therapist or our SLT technical instructors, which are very experienced assistants. And we documented observations on their saliva presentation. I mean, there's little research information out there, but we know the sort of questions that we get asked repeatedly when we're talking about it, and some of the presentation that was at the RCSLT conference in 2001, there was a lot of concern about saliva, any behavioural changes to tell us, is this changing quality of life? Verbal or non-verbal communicative responses. So we included anything given via alternative communication or gesture, facial expression. Also, for those where it was an ongoing intervention, we looked at chest infection frequency, because people are often asking, okay, if the saliva is increased, what is the risk? Or is there really no bolus? Is there pooling there that we're, not seeing externally? So we looked at pre-intervention and post-intervention frequency of chest infection. And 4 of our patients were able to give us a bit more qualitative information, and we can talk you through some of their comments. So our behavioural observation form is here. So first of all, baseline observation, its number of swallows are recorded here, and we would also look at behavioural observations as routine. Some people might be aware of some of those documents that are available in the PDoc toolkit from the RHN website. So that's our standard baseline observation form. We then have their saliva presentation, the flavour offered. I saw one of the questions earlier. So the flavour comes from the drink rather than the powder. So the flavours available, depending on what drinks you have available at your service. How many trials they had, number of swallows, and anything else about their swallow presentation. So was there a change? We might also record there if we were concerned about an increase on noisiness, on inspiration, expiration, voice, or any attempts at swallows, even if a full swallow wasn't present, which is really helpful if you're thinking about, is this a tool for quality of life, or is this something that might lead towards sort of rehab goals? The next is our behavioural responses, and we did sort of colour code them a little bit into the not enjoying, neutral, and more signs of enjoyment. And these could all be circled, and obviously if there were other ones we specified at the bottom, so it was easier to compare across trials if we were getting similar responses. But also if it was a behaviour not seen at rest and was in response to the foam, that would be something that we might check in with their care team if they see that response at other times, and to make sure we're categorizing it correctly in terms of whether it's generally perceived as a positive or a negative response. We know that suction isn't available in all services, but we do have it available here, especially oral suction. Most of our staff are trained, so we just commented if that was required. If there, for some people, there may be a slight increase in saliva, which may not require suction, so we separated those out. So in terms of the behavioural responses, a majority, 58%, were positive, 10% neutral, and 32% negative, as we showed on the previous behavioural observation chart. It wasn't completely stable for each patient, so not all of their behaviours were positive, negative, or neutral, and you could see a mixture in individuals. Saliva monitoring, it was really close, 50-50. And again, it wasn't consistent within patient. So there were some patients that so 4 of the patients had no change in saliva, 5 always had a change, and 4 were mixed results. So, you know, sometimes it changed their saliva production and sometimes not. In all cases, it was easily managed with oral suction, or for one of our trachea patients, a deep suction following the trial. So 64% had it handed over to ward staff to become part of their daily routine. 36% were discontinued. So this was 2 of them were because they could express that choice, that they no longer wanted to, and 3 of them were on behavioural observations, and those patients had severe cognitive impairment. But there was no correlation with tracheostasis. I know a few people in the questions were asking, but there was no correlation between their tracheostomy status and whether it was handed over for long-term use or not. So the results, one of the really reassuring things is no patients had an increase in chest infections. Now we know that there's not a direct correlation between aspiration or what people are having and chest infections, but this was just one of the concerns that repeatedly was brought to us about, is this a risk in introducing a bolus in these patients that are known to have a severe dysphagia. And for many of them, might have been put nil by mouth because trials of eating and drinking at risk weren't successful, or they became unwell repeatedly. We also had a look at what people commented, and we sort of grouped it into 6 main categories. So agreeing that they were enjoying it, requesting more, and these might be verbal or non-verbal signs, that it was satisfying, they enjoyed the taste. We did have 2 that negative taste or no taste when trialed. So some of the positive comments were things like, oh, delicious, I haven't eaten anything for a year. But on the other hand, artificial, nasty. And we did also think about what the foam taste was provided on, because that did in some people change the impact of the taste. So metal versus plastic versus metal spoons. I think also at this point, this is all feedback directly from the patients or patient responses. Also had feedback from a family member about the positive impact of them perceiving the positive behavior. So seeing them looking to be requesting more gave the family member feeding them real joy as well. So for the patients that could give us comments, this is the questionnaire we used, and each time they could give a rating, but also give us a bit of feedback, and I can go through some of the quotes we had. So in terms of improving quality of life, the person that said not at all said it was because they didn't have it often enough. 2 of them said it did improve, but to a variable extent, and said things like, I'm really happy when I taste. It gives me flavour I'd forgotten and is nice. They reported positive changes to feel that I can have tastes even though I have a swallowing problem. It makes me think that I might be able to drink in future and gives me hope. And in terms of the drooling, so one person did rate it as very much, still didn't view it as a problem because it was resolved with oral suction. And the others didn't have an increase in saliva to manage. So I will hand back to Erin.
Musical chair. Okay. So I'm just going to kind of try and pull everything kind of together, really, that we've spoken about. So kind of overall, what have we learned about using flavoured foam, about using Biozoom? And obviously, as you know, Taryn mentioned, we all know, you know, how important and meaningful food is to people. And also, you know, as kind of Zoe shared, some of the patients that we've used it with have been able to express or show very clearly, you know, a strong enjoyment of that taste and flavour. And also, you know, as we've touched on there, it may also give enjoyment perhaps where it wouldn't be anticipated to do so. So, for example, as Taryn mentioned, we had a number of patients in the trial who had a tracheostomy where their tracheostomy cuff around the tracheal tube was inflated, which for those that perhaps aren't as familiar means that the person would have no airflow going in and out through their mouth and nose, which, because of what we know about kind of how your sense of taste and smell work, that would kind of lead you to assume that it would have a really negative impact on their ability to taste anything. So if you've got no airflow there, you know, your sense of taste is severely compromised. But actually, of the 9 patients where the tastes were handed over to ward staff to become part of their day-to-day routine and to have it on a daily basis, 3 of those 9 had a tracheostomy where the cuff was inflated 24 hours, and the patients themselves either showed sufficient signs that they were enjoying it, or they were able to self-report enjoyment and that they could taste it adequately to get that enjoyment from it, and therefore that the foam was continued for those people. Another kind of benefit to it is that, you know, that there's a lower aspiration risk compared to a bolus, simply given the fact that you are putting a far smaller amount of fluid into that person's mouth. compared to giving them, a whole teaspoon, say, of a fluid or a yogurt or what have you. And also we know from kind of research evidence that even when aspiration is occurring, the volume of aspirated material is a key factor in terms of whether somebody will develop an aspiration pneumonia or not. So, the volume of aspirated material is key. So this system does offer, a way of somebody having taste with that much lower volume in terms of a bolus. So the manufacturer's Biozoon, I seem to imply that it can be made from, the foam can be made from any liquid. So I saw that they'd shared something once about somebody having tastes of turkey gravy foam on Christmas Day, so they could enjoy that with their family. We haven't tried it here in terms of making it out of, for example, a very liquid puree or a soup or a gravy. We haven't sort of experimented with that yet. I do wonder whether making it out of something that's food-based would potentially lead to a little bit more residue orally than something that's fluid-based. But that's not something that we've explored as yet, but I'd like to have a go with it and see what it looks like, what it does. Another benefit is that it's a meaningful and motivating choice. So if you've got somebody who's got a very severe brain injury, a very severe dysphagia, it can be quite difficult sometimes, especially in a hospital setting, to find options and activities within therapy tasks to really kind of motivate and engage. And actually, for some people where they have got a very, very, very severe dysphagia and you're not necessarily looking at oral intake or trials, it can offer another opportunity for things like choice making of flavour and things like that could really motivate that person potentially. And then finally there, about social participation. So it allows people who perhaps have been nil by mouth for some time, as our participants in our trial have been, that opportunity to kind of re-engage with friends and family. We've got a gentleman who has regular foam tastes on our ventilator unit, a gentleman with locked-in syndrome, and he has been on a number of pub visits now with his friends where he has foam tastes of gin and tonic down at the pub with his mates, and that's obviously not something that would have been open to him before, and perhaps not something that he would have wanted to engage with as a spectator, but that now that he can participate, that it's opened up those sorts of options for him. In terms of risks then, so we've touched on already, that there is clearly a tiny amount of residue. I don't think that the implication that there is no bolus whatsoever is practical or actually holds up. There must be a tiny amount of fluid in the mouth in order to get the flavour clearly. And the skin of the bubbles is made from the fluid. However, as we've already said, it's a much smaller volume compared to a sip or a teaspoon of fluid. It's still worth considering, I suppose, that you are introducing something new into the saliva, into that kind of that oral place, and something sugary. Again, potentially if you're if it's a sweet sugary drink, there will be a tiny little bit of that sugar in the saliva. We've obviously spoken a lot about saliva management when we sort of shared the results of the trial, because we know that, as we mentioned, that's where a lot of anxiety about using something like this or trying something like this comes from. And obviously we would expect some saliva increase as part of the normal human response to gustatory stimuli, so it's quite natural to experience that. I know myself, when I've had a play with the foam and tasted it, and these guys are nodding in the background, I myself get a very strong feeling of, okay, there's loads of saliva coming now because of that taste, even though there's nothing there to swallow. And obviously the problem with for our severely dysphagic patients is that although what for me is an easily managed increase in saliva because I just swallow it, for patients with very severe dysphagia, obviously that increase in saliva could pose a risk of them in terms of aspirating that secretion. As Zoe already outlined, for everybody in our trial, we were able to manage that oral increase adequately with Yanka suction, but we know that not everybody will have that on hand. In our hospital setting, we have a Yanka machine at every bedside, so it was really easy for us. It's definitely something to consider if you're using it in a different setting, like out in the community, how you'd manage that if there was, a significant increase in saliva and what kind of risk that might pose to that specific individual. And I think what we found here is that even if it does increase somebody's saliva, production in response to that taste, You know, and even if management of that is perhaps a little bit more problematic, or it causes the person to cough, you know, that in itself doesn't necessarily mean that you know, the Biozoon is not an option for that person. It just means that the discomfort perhaps associated with it, and any risks around aspiration of secretions associated with having the foam taste, is considered either by the capacitous patient, and we support them to do that, or as part of a kind of a best interests decision. And then sort of the final kind of key risk that we're aware of around it is about the allergen. So one of the 2 ingredients in that little sachet of stabilizing powder is soya lecithin, which I can't say very well. And that is an allergen. So soya is an allergen. So that needs to be considered, you know, and just checking in, you know, has the patient got a soya allergy? So overall, from our kind of study, what we found, the conclusion that we've come to, is that flavoured foam taste can play a part in enhancing quality of life in some people with severe dysphagia who are nil by mouth. And it's really important, I think, to note that not every patient appeared to get enjoyment from having the foam tastes, based on both the behavioural responses from patients who couldn't kind of tell us, you know, volitionally, because of their communicative and cognitive impairments, what they thought of it, and also from some patients who were able to decline further taste outright because they were able to express clearly they didn't like it. And I think, you know, it really highlights the importance of being patient-led, and that there isn't certainly up until this point now, we haven't found a kind of consistent formula at all about which patients might benefit from trying this and which patients won't. And for, you know, people who are potentially, you know, longer term, the prospect of being nil by mouth in the longer term, it might offer a halfway house, a compromise between being nil by mouth and eat and drinking with acknowledged risks, or EDAR, or risk feeding, where somebody has oral intake where the risks of aspiration and choking and pneumonias and so forth are acknowledged. I think, you know, the risks associated with EDAR are likely to be higher, you know, in terms of the risks of developing an aspiration pneumonia, for example. However, the benefits would also be greater, and that there'd be a greater range of food options for them, and, you know, different flavours and actual meals. So the risks and the benefits of EDAR are perhaps higher. But for some people, Biozoon or Flavoured Foam might offer kind of an in-between option, which, you know, we just, with the client group that we work with, you know, we find really interesting and really useful to have. Just to whiz through some practical considerations. What time are we on now? Yeah. Okay, we've got time. Good. Just to whiz through some practical considerations. In terms of funding for the device, so when I last checked on the website, the initial payment for a starter pack, which gives you the pump part and some of the pipettes and then some of the sachets, is about £36. So it's not, you know, a hugely costly piece of equipment. The consumables, so the little sachets of powder that you use to stabilize the drink, you can buy them in bulk, so it's about £29.95 for a pack of 100 of those. And the little pipettes, which, as Taryn said, are single use, you could get 90 of those for about £30. And obviously for each individual drink that the person has, you know, they need one powder sachet, one pipette, and then obviously they're used and disposed of. So although the initial cost isn't necessarily, you know, very high, certainly compared to a lot of, you know, other bits of kit and things that we might be looking at for patients, you do have to give consideration about that ongoing funding for the consumables, for the pipettes and the powder, as kind of part of that. So however it's funded, whoever's funding it, that understanding that there is that ongoing commitment to allow it to continue to be used. Also, just reflecting a little bit on the training that we've done here. So we've tended to do kind of patient-specific training. So rather than sort of just training all of our ward staff to use it en masse, we've tended to train specific wards and specific, you know, groups of staff as and when we're handing it across for ongoing use for particular patients. You know, and we'll talk about kind of obviously practically how to do it, and give demonstrations and get them to have a go. But we'll also talk about, you know, how much, how often to give the foam, how to manage any saliva increase for that individual, you know, to make sure that they're only giving the foam and not, you know, when the bubbles kind of pop down and it goes back down towards the fluid, to make sure they're not accidentally giving a spoon of the fluid instead. But generally, it's straightforward to use, you know, and the staff, you know, have cracked on and got on with it really quickly. We do put in place, in terms of guidelines, a Mealmat specifically about Biozoon. So all of our patients here at the RHN who are eating and drinking have a Mealmat put in place. So we put the patient name and the date at the top there. And then for a patient having oral intake, the purple bar there would describe what texture of food and what texture of fluid using the IDSI guidelines. But we've made this specific one for anybody who's just having Biozoon. And obviously we would add additional details to it regarding any setup, how much help the person needs, can they do it themselves, do they need you to do it, do they need to be fed, do they need hand over hand, and so on. Any sort of things around communication, helping that individual to make choices if they can, or signs of pleasure, signs of dislike. We'll put in the swallowing strategies box there with the red outline around it, sort of perhaps if there was a specific issue around it causing a problematic increase in saliva, we might give, you know, an instruction to give Yanka suction every however many teaspoons or as needed. And we generally advise people that if the person's unwell, if they've got a chest infection, and there's concerns about their chest status, you know, not to give in that incidence. And then the back of the Mealmat there, we've come up with, you know, a bullet pointed list, kind of step by step of how to make the foam. And then also at the bottom there, you know, just some extra kind of tips and tricks and bits of information for them really, to kind of facilitate that. I just wanted to quickly share as well, so lots of people have been asking us recently for our infection control protocol, because I think from what I gather, different hospitals and different SLT teams that are looking at this are coming across you know, perhaps some barriers from an infection control point of view, and what their infection control teams are kind of happy with or not. So our infection control lead here came up with this protocol with us. So we have a number, how many think now, maybe 5 of the Biozoon devices across our hospital, across the SLT team.
And a couple of patients that have self-purchased,
that have bought their own, and a couple of the wards, in fact, have got them for, you know, if there's several patients using it on the ward, then the ward have funded, you know, so there's a range of different devices in the hospital, different funding streams. But the ones that we use in speech and language therapy, you know, we obviously want to be able to use them across lots of different patients, especially when we're just doing a trial, because we don't know whether it's going to be beneficial for that individual or not. So we have been authorised to use a single pump across the patient group. So what we've been asked to do basically is just make sure that we wipe down thoroughly the pump itself and the silicone tubing with Questionnaire after each use. And they were happy with that because the actual fluid in the cup doesn't come in contact with that silicone tubing. It only comes in contact with the pipette. And obviously the pipette is blowing air out. It's not sort of sucking the fluid up into it. So that the tubing inside, you know, just stay very clean. So we're okay to use the Questionnaire wipes to wipe that down here. And obviously, as we've already said, the powder sachets and the pipettes are single use only. Okay. So just some final thoughts before we try and hopefully get on to some of the questions that I think people are busy popping into the Q&A. Just to kind of summarise really, what we found here is that not everybody enjoys or wants it when you trial it, but for some people it absolutely can enhance their quality of life, and for some people very, very significantly. The saliva burden is kind of attributed to it, and the risks of that need individual assessment and consideration. And there's you know, there, as with any decision making around dysphagia, I think there is no one size fits all. It needs to be considered, and you know, the management of any, you know, saliva issues are considered and weighed up and you know, taken into consideration. I think there's a really big range of potential applications. You know, we touched on some of the ways that we're using it here. I think, you know, that there is a much wider number of kind of people, you know, populations and client groups that could potentially, some of those individuals within that, you know, could really benefit from something like this. And absolutely, like, more research is needed. As we've said, there isn't anything at the moment. We're currently beavering away trying to finish the final draft of the study and the data that we've managed to pull out and write it up so we can get it published. so that hopefully, you know, people can kind of, you know, take some of the information and the pros and cons and the things that we've learned and apply it, and hopefully, you know, more people will do sort of more research and more projects with it as well. And I just wanted to finish with this quote here from a patient who said, "I haven't had anything past my lips in 10 years, so it tastes wonderful." And that was after I had given him his first taste of a cup of tea, a strong cup of tea of the foam made from the cup of tea. And he was the very first patient that I tried it with. He was pretty much the first patient that we tried it with here at the RHN. And he had an entirely absent swallow after his brain injury and had, as he says there, been no by mouth for a very, very long time. And his face when I gave him that first spoonful, it stays with me to this day, because it was just such a picture. And he certainly got an awful lot from it. And you know, he's sadly passed away now, unfortunately, but I think he would be very pleased to have got the final word in here. Okay. So any questions?
Scribbling some down. So I've got some of the questions from this first half. Hopefully we've answered a lot of them as we've gone through.
So we've answered, just skip over
exactly. Yeah. So someone asked about other products on the market that do the same thing. I'm not aware of any, but if anyone is, do feel free to pop it in the Q&A box for us.
Not that I've come across either.
No. Any hard to use liquids? I haven't come across a liquid, and someone asked specifically about fizzy drinks. I've done it with fizzy drink, fine. Just make sure you got a big enough cup.
And also it's like when you're trying to thicken a fizzy drink, I would absolutely suggest give it a really good stir first, get some of the fizz out before you try and put the powder sachet in, because it will go. But other than that, it's fine. It works for the flavour of the drink. It works. And they say we've had patients here, you know, having it with gin and tonics. We've had people trying it with sort of all sorts of different, you know, weird and wonderful drinks and things. So
I would say though, the metal spoon had a really big impact, especially with those fizzy drinks for some reason. Don't know if it's the metal reaction with the drink. So, but once we switched off the metal spoon onto like the hard plastics, you know, maroon
like
Captex,
a nylon coated spoon.
Then they really enjoyed it. So where to buy? We buy them online.
So there's the Biozoon website. And if you just Google Biozoon, what comes up.
Someone asked about NHS funding. I mean, it's at that cost, that wouldn't be a separately NHS.
Well, you say that. I think it depends. So we've a lot of the people that we've used it with here have kind of been longer term residents, but we have had a lady quite recently who was discharged home who was using it regularly, and actually her CCG did fund it. We had to put it through as like this weird little, I had to fill out this very strange form that I'd never seen before, but that you know, really made the case for kind of her quality of life and well-being and so forth. And they funded it, and they committed to funding the consumables going forwards as well. So I'm not entirely sure what pot of money it's coming out of, but they did. So again, I think it probably varies very much depending on your CCG.
What they're worth trying.
Someone on the chat had it funded.
Someone saying we have someone who has the consumables agreed and funded by CHC, so it can be done. And again, I expect it's a bit of a postcode lottery, unfortunately.
There's a question about rechargeable batteries.
They seem to last a very long time. The batteries. I can't.
But I don't know if we're using rechargeables.
I don't think we are.
I think we might be using disposables. Unfortunately.
I mean, it's you can't comment really. It's an electrical device. I'm not sure what the specific instructions say to use or not. We're using standard batteries with it. It'll be something for you to explore whether you could make it work for your service with rechargeables and that's compatible with the device. Don't know.
Good question.
Would we be happy for forms to be replicated with reference to RHN? Yes, definitely. And lots of people have been emailing us, and we've been sharing the, you know, our protocol and our infection control, you know, policy and things with regards to it very freely. So yes, you will receive the slides from today on email, and the video itself is going to be on our RHN YouTube channel apparently as well. So yes, by all means. And I'm happy to pop my email address down in the chat if anybody wants to get in touch, and we can ping, you know, we can ping through that protocol to you.
And asking about the blog post details, so we could pop that on the
it's in the
as
reference
well.
list
It's in the
already.
reference.
It's in the reference list. So when you get the slides, the blog post is in the reference list too.
Yeah,
So
really
see that.
interesting read.
Yeah.
A few people asked about saliva management. I know we touched on it. The reason we haven't gotten into details about the saliva management protocol, completely different for each individual. And in fact, we have a specialist clinic here, specialist multidisciplinary saliva clinic, and it varies, but there were no exclusion criteria. There was no level of saliva management that excluded.
And in fact, I think as we mentioned, every single patient in the trial, all 14 were on some form of saliva management medication or saliva gland Botox. So particularly, perhaps for those who had the Botox, the kind of the more severe end of the saliva management difficulty spectrum. But also, I think it's fair to say that although their saliva had hopefully been optimized as much as possible, just because they had saliva gland Botox or were on lots of medication does not necessarily mean for our patients that their saliva is, and that there's no issues. Often, there are still ongoing issues with, with saliva.
Someone's asked, does it actually stimulate a swallow? Depends on the patient.
Yeah.
It's been different, and
it obviously is going to, somebody with an absent swallow who doesn't swallow in response to any stimuli, probably not. But I suppose, again, we haven't looked at this in any scientific way, have we? But in terms of, the flavour and the taste, it's certainly, when we've tried it ourselves, it's easier to swallow that than it would be if someone just said to you, do a swallow.
Yeah.
So from that point of view.
And I have had patients that don't swallow at rest on saliva, that have shown some, either attempts to or full swallows with the flavour, and the same changes. So for your really long-term patients, I had a lady who was started on the foam tastes, who had an oral preparatory response, but without a swallow response initially, but had it for a number of months and did begin swallowing. We have no scientific evidence that this supported the change, but then it did give that person quality of life, and it did give that person opportunities with someone prompting a swallow. So whether it's that prompting or the opportunity or the motivation or the actual physical stimuli, I hope more people out there will do some research studies following our publication and look at some of these things. Is someone doing some research there? Oh, lovely.
It's got a publication out.
Oh, wow.
Oh, fantastic. I look forward to reading that, because someone was also asking about if it stimulates gut responses. Not something we researched, but I hope people will start doing some more research for different client groups and what impact it has.
There were also a couple of questions around the pipettes and the reason for those being single use. So like we mentioned, we use it in one session with the patient, but there was concern about the moisture going into the pipettes and it not being able to
I think if you washed it, getting the moisture out via all those pipettes,
it wouldn't be able to dry properly very easily, like between uses. And also I think the little tiny air holes, there'd be the risk that you wouldn't necessarily be able to flush that through. It wouldn't necessarily always be flushed through adequately, and then you've got the risk of, I guess, bacteria and things sort of growing within it. So yeah,
again, it's a risk management thing. It's not something that we've researched here. So if someone is doing research on microbes in consumables,
that is what the manufacturers say, that they are single use. But as to how that's interpreted, by other people in practice, but we're at the moment we're following that and using it as a single use tool. Anything else coming in?
I'm sorry. Someone asked about diabetes and allergies. Obviously, we answered the allergy question. In terms of diabetes, our medical teams haven't had concerns with our diabetic patients weren't excluded. We did always talk to the medical team about the starting. I think because of the amounts, the volume is so
minimal. And also, in terms of, there's patients here on all sorts of different medications that ideally wouldn't be given, for example, with alcohol. So if somebody's saying, oh yes, I want to try this, the same gentleman who wanted gin and tonic also wanted some Cornish beer and some ale to try it with, so when we started to express all of this, we were talking with the medics, is this okay? And they were like, yeah, although we wouldn't necessarily want somebody drinking, a pint on some of these medications, a taste of it, of this foam, you know, the volume that's going into their body is so minimal. They were happy with that. But I think it's always just about checking, you know, from a medical point of view, you know, and make sure that they're happy, really. So you're covered, I guess, from that angle. Somebody else is asking sort of how many teaspoons do we give, and sort of how do we decide that? I mean, I think we kind of base it on the individual, really. You know, we
It's their responses, really. Do they get fatigued? Do they stop opening their mouth?
Does the saliva start to kind of build up and become a bit more problematic if they have, you know, have quite a lot? So it kind of, we're kind of led by them, really. I don't think we've had a situation where we've had somebody having, you know, like 40 teaspoons. It tends to be, you know, up to maybe say 10 or 12 at a time. Say,
I think I have one person on 20, and that's because they liked having 2 different flavored things, and so they'd do 10 of one and 10 of another to make it more, you know,
so you kind of
an event.
In the same way that you decide for anybody, if you're starting them off on oral intake, you know, if you're starting them on, you know, tasters of something, you would use your judgment. You would use how many spoons should they have based on your assessment.
Any other questions coming in?
Quite a few questions on if anyone's using it actively in therapy and part of rehabilitation. So it's something we're using here.
I think it's been a little bit more ad hoc, hasn't it, so far, in terms of using it for rehabilitation. I think it's definitely something that would be really useful, you know, if anybody is doing anything else out there, or any other kind of studies or anything, you know, to look at that, because it's definitely another application of it, isn't it?
Well, maybe that's our next one. We've done quite a bit on quality of life. We'll have a look at our rehab outcomes on it. We're just looking at the screen that has all the questions.
We've covered most things. Are there any that kind of come on as we've been talking?
Did you? Oh, someone asked about one-way valve and trachea. Yes, depending on the patient, we will trial it in all conditions. So cuff up, cuff down, one-way valve, even digital occlusion, if they're better with momentary. It's completely patient-centered, and I think it works for them.
You know, just using logical sense as well. You know, if somebody is tolerating some periods where they've got cuff down and one-way valve in situ, they've got that airflow, they're probably going to taste it more and get more enjoyment from it. Their airway is less protected if there is that salivary increase, so it's that kind of that balancing act. But certainly we had a lady here who was having it regularly initially with trachea cuff up, and she had real problems with saliva management. Nothing was kind of touching it in terms of kind of reducing, and we ended up in a situation where to give her some periods each day where she could tolerate cuff down and one-way valve to speak to her children. She was having a couple of stints a day where she had atropine drops under her tongue, because that was the only thing that really seemed to crack it. So if we gave her the atropine sublingually, she'd then have, you know, an hour where, you know, we could get the cuff down one-way valve on. So when that started to happen regularly and she was tolerating that, we moved her Biozoom tastes into that time, so that because she got more enjoyment from it and a stronger taste, which had the one-way valve, and that's what, you know, what worked best for her. So again, it's patient specific.
We even had in fact we've had a couple of people with really tight jaws that have a lot of difficulty mouth opening, but they find the foam tastes really motivating, and that they will tolerate quite a lot of jaw opening facilitation and stretch in order to get the foam taste. So again, that wouldn't be an exclusion criteria if that's something the patient, you know, wants to do and shows enjoyment with. It's a good tool there.
There's also a couple of questions about how do we go about picking flavors or the drinks for patients who can't express it themselves, and I think particularly for our PDOC patients, we're in that situation, and we try to speak to family members and gather information from them and try and find out what preferred drinks are for them. And we do sometimes also try drinks that perhaps they wouldn't like, to see if there's any difference in their responses, especially when we're using it for our PDOC assessments.
And especially because tastes change, as we all know, you know, post brain injury, and especially post a significant period nil by mouth, their taste might have changed. And you will notice on our form, we note in each trial which flavour, so that we keep a record of that.
Seems like hopefully we have answered.
I think we've answered most of
the questions.
Like we say, we're happy if people send us questions after the event. If you think of it as soon as we log out, do feel free to forward it, and we'll try and get back to you via email. And please keep us updated if anyone else is doing some research and has some results to feedback.
Brilliant. Thanks for joining us.
Thanks. Thanks so much.
Thank you. Bye-bye.